Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Thanks, Sarah. Hello, everyone. Thanks for having me. So I'm really excited about this topic. There's actually a lot to cover. And obviously, we begin with the letter A. And when we talk about the letter A, I actually wanted to talk about three things. So the first what I want to talk about is antibodies, because I think they're really important to understand. And some of these content that I'm going to talk about, I think some of you might already know what they are, but I think it's a good refresher and just to gain more understanding. So A is for antibodies. These are proteins that are made by the immune system to help us defend against, harmful invaders, viruses, bacteria, and toxins. They're like your bodyguards, essentially. And they're produced by these cells called B cells. And here I'm illustrating a B cell, just a simplified diagram that is producing antibodies that are binding to these bacteria and viruses. And once bound, what happens is they allow the immune system and other cells and other components of the immune system to attack and essentially remove these toxins, these harmful agents. Now, antibodies are very unique because each antibody, they're very specific. They bind to specific parts. So, when you get vaccinated, for example, you're allowing the immune system, the B cells, to produce specific antibodies against that particular vaccine. So when you're exposed to some infection that vaccine is meant to help you, it sort of is ready to combat that problem. So in this diagram, you can see that the antibody has a section on the top, and this is a typical shape. It's like a Y shape. It has a specific binding region, and it binds and it latches on, allowing the immune system to attack it. But the antibody can also become a problem in some patients, in some people, whereby you develop autoimmunity. So an autoantibody is a type of antibody that goes a bit crazy and essentially targets your own cells, your own tissues. And it doesn't mean that you have an autoimmune disease, but it can lead to an autoimmune disease. So just drawing it out diagrammatically, these autoantibodies, they're produced by abnormal B cells for whatever reason. And here I'm trying to represent in red these autoantibodies that target certain parts of your body. So commonly what we see in rheumatology are, problems with joints like arthritis. So these autoantibodies, they target the joints. And as a result, as we have learned, they allow the immune system to attack it. And that's why the joint can then become swollen, inflamed, and hot. So the next A, I hope that makes sense. And I'm happy to ask, I'm happy to get questions once I get through a few. The next A that I thought was very important is autoimmune diseases. Now, everyone has an immune system, as we have learned, because it helps protect us from, again, harmful agents. So here I'm just drawing out a healthy person with, normal, I'm going to say normal immune system, because they have no autoantibodies and they have no other immune cells that are sort of targeting their own body. But then, some people, and I think, and to be honest, I think everyone has a varying degree of autoimmunity, meaning that their immune system to some degree are not perfect. And it's not abnormal, it is fairly normal for their immune system to, start throwing off some autoantibodies here and there, but not necessarily causing a problem. They live a normal, completely normal life. And here is a representation of what I call autoimmunity, whereby the person is healthy, but they do have, autoantibodies present, but it's not causing any issues. And so an autoimmune disease is when these autoantibodies and this immune system actually causes a problem. And here I'm representing a person having a painful shoulder and a painful knee because of their immune system and the autoimmunity causing an actual problem. So there are many types of autoimmune diseases, and I know a lot of you are aware of this. Multiple sclerosis is one that affects the brain and nervous system. You have something called inflammatory bowel disease affecting the bowel, type 1 diabetes affecting the pancreas that produces insulin, Hashimoto's thyroiditis of the thyroid gland, and celiac disease, and also psoriasis that some people have, which are scaly patches. Now, these are all autoimmune diseases. Rheumatologists actually deal with, I think, the most autoimmune diseases amongst all these other specialties, because we deal with both the joints, but also systemic tissue diseases. So we see a spectrum of autoimmune diseases, just to name. And these are some of these we obviously don't treat, like multiple sclerosis are really the neurologists and the brain doctors treat. Now, I talked about antibodies. I talked about autoimmune disease. And Sarah was telling me one of the hot topics is ANA. And I thought I have to talk about, this is the final A, I promise. A is for ANA. So what is ANA? And I think a lot of you guys have heard about this. And honestly, we see a lot of people come into our clinics with a positive ANA. ANA stands for anti-nuclear antibody. And ANA is actually an autoantibody, which I already talked about earlier. So it is a type of autoantibody that specifically targets structures within the nucleus of a person's own cell. So what does this mean? Here I'm drawing out, again, you can see the diagram from earlier, the abnormal B cells producing autoantibodies. In this one, you can see a B cell producing what's called an ANA, anti-nuclear antibody. We are all made up of what's called cells. These are our building blocks. Our skin, our brain, our heart, our lungs are they're all made up of what's called cells, which are the building block of who we are. So here I'm just representing a hand just for like the skin, for example. And our skin contains cells, special cells. And each cell, they have what's called the nucleus, which is basically the center hub. And within this hub, you can find your genetic material and whatnot. ANA is anti-nuclear antibody. So it literally are antibodies against the nucleus of the cell. So drawing it out, it's literally antibodies that are targeting the nucleus of the cell. I hope that all makes sense. So, now antibodies are not very specific. Having a positive ANA doesn't really tell us what sort of condition or autoimmune disease someone has. And the reason for this is it really can bind onto anything within that cell nucleus. And there are many, many, many structures within the nucleus of the cell. Now, I'm just going to go into a bit more detail, and I'm sorry if I'm going to confuse anyone, but I think it's really, really interesting. So when we look at ANA, what we're very interested in is two things. One is how strong the ANA is. And we define this by a number. The higher the ANA number means it's a very strong positive result. That's one thing we look at. The second thing we look at is the pattern, what it looks like under a microscope. So hold that thought. This is how the test is actually done. They take blood from you and they put it in this dish here containing already pre-made cells. They put your blood here and then they sort of wash it all out. So it basically allows any antibodies in your blood to latch onto the cells that are already there. And then they put basically like a dye in, some dye, fluorescent dye, to essentially show what is lighting up within that dish. And so based on that, you get scientists that look under the microscope and they can actually see what kind of pattern the ANA is. So remember, the two things I said was important about ANA is how strong it is and the pattern. So when they look at it under a microscope, you can see so many patterns of the ANA. Some people might not even have an ANA negative, but they can also have a whole host of patterns I'm showing you below. And I'm not going to bore you with all of it, but there's specific patterns. And why are these patterns important? These are the patterns you see under a microscope. Why are they important? Because some patterns are actually more associated and linked to some autoimmune diseases, such as lupus, such as systemic sclerosis that we see. And I guess the other thing is using this technique, and by diluting it, you can actually assess how strong the ANA is, and they'll give you a number. The scientists will give you a number. Now, I hope I didn't really scare you all by saying, a positive ANA really means some sort of autoimmune disease, because a positive ANA does not mean you have an autoimmune disease. Because there are many things that can actually cause a positive ANA aside from an autoimmune disease. So, for example, if you had COVID or if you were sick and we checked your blood, you would have a positive ANA. Or if you were unwell with a chronic illness, such as like a bronchiectasis or even liver disease, that would also cause a positive ANA. In fact, up to 20% of the general population have a positive ANA, and they're completely healthy. Obviously, the levels vary between individuals. So, for example, you know how I said that there are, the number, how strong the ANA is. The higher the ANA, the more associated it is with autoimmune disease. But again, it's also very common in the general population. There are some ethnic groups that are where you see higher percentage of the ANA, which are more closer to 20%. So these are like the Southeast Asians or China, for example. So I think the take-home message is a positive ANA, it does mean some degree of autoimmunity, but does not necessarily mean an autoimmune disease. I'm very happy to answer questions, but before that, I'm just going to show you one table. This is a study, and I think this is very interesting. This is a study that's just showing you how common an ANA is in the general. This is just one study, but it's pretty much the same. This was a study that looked at how common an ANA is in the general healthy population. So you can see a low number, ANA titer, up like 30%. Obviously, the higher the ANA is, it's 3% of the healthy population. So we don't only look at ANA, we have to look at the person and the symptoms and other blood results.
Ready for
I'm happy for questions. Yep.
Well done. Guys, we're only at A, so buckle up. It's going to be...
That's a lot. Sorry.
Okay, Vanessa's asked a great question. So when you went through the patterns and the scale, so she's asked, when you get a blood test, does the technician only look at the positivity versus negativity, or do they report on the patterns and they report on those other sort of things that you mentioned? Or when you get a report, do you just get it's ANA positive and that's the extent of it?
Yeah, I think what's really interesting, an ANA, I'm going to answer that question, but if you go to different laboratories, so there's Lavity, there's Douglas Hanley Moore, if you go to different labs in different, who give it to different sort of laboratories, they will all give you different ANA results. Not completely different. So for example, one lab might give you 1 in 80, the other lab might give you 1 in 40 or 1 in 160. So that's just very important to know. And the reason for that is it's actually a manual task. You actually get people looking and seeing these ANAs. What we get in our clinic is essentially a titer. So we're relying on the laboratory to give us an accurate reading, the titer, and they also give us a pattern. So we get two things.
Okay, gotcha. Thank you. Just remind me, Armando, are we going to cover seronegative RA? Is that on the list to know?
No, it's not.
Okay.
But
Because someone's asked, and if as long as it won't take too long, can you talk about ANA for people that have seronegative RA? Is there a correlation between the two? Would you expect someone to
yes,
have a positive ANA if they had
yes,
that?
I see. So if someone has a seronegative rheumatoid arthritis,
Mhm.
but a positive ANA, I think that's a very, really good question. So we are not, so as a general rule in rheumatology, as a general rule, because I've done so many studies, if it's just arthritis, um, if it's just arthritis, which is the main manifestation or symptom, and you have a positive ANA, we would only be maybe interested in it if it was a very high titer with a specific pattern. So 1 in 320, the one I have here, it's really like what we're interested in, the minimum. But if it's only, if it's only joint pain, so seronegative rheumatoid arthritis and a positive ANA, without any other features like rashes, we look at many other symptoms. We wouldn't say it's seropositive based on that ANA. I hope that answered that question. Sorry, I was doing a loop.
So, but would you expect someone, say with just rheumatoid arthritis, would it be likely that all of them also have a positive ANA or not
Oh,
necessarily?
no, not
Okay.
necessarily. As I said, like, I know the general healthy population is 30% or 20, like 10 to 20% up to 30. It's not, no, not necessarily.
Okay, cool. All right, I've got a couple more questions. I thought ANA is always a juicy one. So Elizabeth asked, with ANA patterns, well noted, certain patterns are more suggestive with certain conditions, or they're more correlated with certain conditions. So often the DFS is not for autoimmune, but is there potential of high positivity, but DFS patterns suggest early onset or development of an autoimmune condition?
Yeah, actually, that's very good. And I didn't get into all the patterns in detail, but DFS, for those who don't know, it means dense, fine speckled pattern. They've done studies and really looked into it, and both short term and long term, and it's a negative correlation. So if you have a dense fine speckle, you are very unlikely to have an autoimmune problem associated with that. Doesn't mean you can't develop rheumatoid arthritis or something, but there are certain autoimmune conditions that are associated with that. Yeah.
And on that then, because thanks Elizabeth for sharing, they've had a couple of patterns over time. So can things change? Someone else has asked, they were positive for many years, but now they're negative. So
Well, yeah, I mean, that's exactly, so I alluded to it earlier. As I said, if you go to a different lab, both in the same state or a different state, they will give you different patterns. They will give you different results, varying results, not too much. But the labs don't tend to report an ANA that is less than 1 in 80. So in Australia, at least, we never get 1 in 40. If so, they will just say it's not detected because there is no there's no a titer that low is really not really associated with autoimmunity. As I said, the higher the titer, and we get more excited if it's like, over 1,000 basically, because that's more, there's more, something more in it. But you would, I think it would be very unlikely to have a blood test, for example, in New South Wales that show, 1 in 80, but then you go to Queensland and it's like 1 in 1,280. I find that very unlikely. However, saying that, if you have a negative ANA or a very low ANA right now, and in 5 to 10 years, you develop some funny symptoms and signs and the ANA changes, that is important because that might be a correlation. So an ANA is a test that, people shouldn't just do because they just want to monitor. They should only do it if it's clinically relevant, if you've developed symptoms or signs that are suspicious for an autoimmune problem.
Okay. Good one. Okay, on to B. Go for
Okay,
it. Leave A&A for now.
I'll zoom to. I didn't know this was going to take this long. So
That's
B is for
okay. It's the
biologics.
first one. It's great.
Yeah.
Relax.
B is for biologics. Now, I'm sure some of you here are possibly on some biologics, and it's a very unique drug. I think what's important to know is that you have you have regular medications. These are like aspirin, your Nurofen. These are all chemically synthesized in a laboratory, right? Biologics are actually made from sort of engineered living cells. So this is very important because what they do is that they basically make these cells, these engineered cells, to produce specific proteins in the lab. And then once they produce a specific protein, they want to produce a specific protein that will actually target something very specific. And that thing that's very specific is a chemical that is released during inflammation. So this is just drawing it out for you. So you have in the lab, they have a cell that produces these specific proteins. These specific proteins then get cleaned, purified, and then packaged into what we call a biologic. And there's so many different types. And each of these biologics that we use for different autoimmune diseases, they target specific chemicals or specific parts of the immune system. And I'm just going to show you some examples, but you've got things called TNF inhibitors because they target a chemical called TNF, which is important in inflammation. You have interleukin inhibitors, and you have also inhibitors of the B cells that produce these autoantibodies. So there's different biologics that specifically target the immune system. Now, because they target specific parts of the immune system, what they are technically, they're technically immunosuppressants. But by suppressing the specific part of the immune system that is contributing to the autoimmune disease, they're reducing the inflammation and reducing the problem. So biologics, they target specific parts of the immune system to reduce inflammation, but they're also immunosuppressive. Now, C is for CRP. CRP is a blood test that rheumatologists love. At least I love CRP. CRP stands for C-reactive protein, and it's a substance that's essentially produced by the liver. It's produced by your liver in response to inflammation. And we measure it. We measure it to assess for acute inflammation or recent inflammation. So this is just drawing it out diagrammatically. So when you have inflammation, it actually stimulates the liver to produce this chemical called CRP, and it goes into your blood. There are many things that can stimulate or cause inflammation. These include infection, physical trauma, flare of a disease, and I mean by like autoimmune disease, cancer, and also being overweight. I'm just sharing you this so you understand that there are many causes of an elevated CRP. However, each of these causes cause a varying degree of CRP increase. The most common cause by far is infection and autoimmune disease, by far. Now, the liver also releases other things as a response to inflammation. And some rheumatologists, as well as doctors, they look at these other markers. Fibrinogen is something, ferritin, which is part of your iron studies, and something called amyloid A. But these are just things to like interesting. There are other markers of inflammation, but CRP is the most common. Now, CRP is used for acute inflammation. Then there's another blood test that we use for chronic inflammation. This is like long-standing inflammation. This is called ESR. And ESR tends to rise in your blood after 24 to 48 hours after inflammation. But it's less specific because as people age, this can also go up. D is for DMARDs. DMARDs essentially stands for disease-modifying anti-rheumatic drugs. DMARDs are our friend, rheumatologist friends, and we use it for a number of rheumatological diseases. The most common, for example, is rheumatoid arthritis and psoriatic arthritis. And they're a group of medications that are typically taken orally that slow down and stop the immune system attacking, healthy joints or tissues. They're typically oral tablets, and that's why there's a person taking a tablet in the background. So remember this diagram I showed you earlier. I talked about biologics, and then I talked about the regular medications that are synthesized in the lab. Well, DMARDs are technically these medications that are synthesized in the labs. They're not, they're not created by some engineered cell in the lab. They're actually synthesized chemicals. So these are your DMARDs. And we have 4 important DMARDs that we use. These are methotrexate, hydroxychloroquine, leflunomide or Arava, and sulfasalazine. These are your DMARDs. And your biologics, if you remember, they are used to target specific parts of your immune system. So you can imagine them like a laser gun targeting specific things. The DMARD is more of a general immunosuppressant. So they treat the immune system, they target the immune system broadly. They're like a blanket rather than a laser gun. And both, again, the goal is to reduce inflammation and to control the autoimmune disease.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.